investigations with lasers and periodontics started in the 90s. In the late 90s, we were looking at microsurgical procedures because the literature was coming up with techniques that showed that if you could do a minimally invasive surgery, that the results from that surgery were almost twice that we would get from a conventional type of flap. So the problem with using the microsurgical instrumentation to do the surgery was we'd use these microblades and make an incision at the crest of the gingiva and then down to the crest of bone. And there would be so much bleeding into the pocket site that you couldn't see what you were doing. On top of that, we know that periodontal disease is an infection that not only is in the soft tissue, but it's in the surface of the root as well. So just being able to remove one surface or treat one type of tissue wasn't enough. Initially, I thought I would need two different lasers. I thought I'd need one laser to remove the lining epithelium, and then maybe another laser or another type of instrumentation to treat the root of the tooth. Well, about 8 or 9 years ago, we came across the YSGG laser, the water lathe, and it answered a lot of those questions for us. As you can see in that first slide, when I make an incision through soft tissue with a laser, I don't get the swelling that I get with like with a scalpel. I also don't get the bleeding or the pain that you'd experience with a scalpel either. And the biggest thing was I could see what I was doing. The water lathe, the handpiece, has a water and air control that allow you to keep the surgical site clean as you're working in it. And by varying the pulses, both their duration and their repetition rate, you can have different effects on the soft tissues. You can not only make an incision that bleeds little or none, but you can also use that same laser aimed at the surface of the root to clean endotoxin and bacteria off the surface of the root. So now we could see what we were doing, and we've got a tool that will let us treat both the soft and the hard tissues at the same time. Another big aspect of using lasers, especially in like 4 to 6 millimeter pockets, was being able to do surgery with topical anesthetics. Imagine doing gum surgery without making incisions, without having to give local anesthetic everywhere that you do it. And that changed patients' perception of the procedure dramatically. Just imagine if your patients know that they're not going to get shot, it makes the procedure much more attractive to them. And having a minimally invasive procedure, well, that just changes the scope and the patient's perception of what they've just received totally. Not having to lay an open flap to do your surgery, it dramatically increases patients' acceptance of the treatment, and it enhances the outcome as well. In the literature, we found that both the erbium YAG and the erbium YSGG laser will kill bacteria in a periodontal pocket. Another side benefit of that is in treating patients that are medically compromised. I found that if I were to treat my patients that have diabetes that are compromised, or say that their diabetic control is just not as good as it could be, you know that if you were to make an incision in their tissue, they may not heal well. Well, I can turn around and I can use my water lathes to treat a diabetic patient and get beautiful results without having to worry about the healing response, because the surgery is so minimally invasive, even borderline controlled or uncontrolled diabetics heal from this type of procedure. Another thing that really changed my practice, I think I must have had every desensitizer known to man in my shelves. I'm sure you're aware that after periodontal treatment, many of your patients' teeth are sensitive to hot and cold, and eating ice cream or drinking iced tea it's really an issue. We found that after treating their roots with the YSGG laser, we didn't have a root sensitivity after the surgery. That made a huge difference in our practice. We also found that by controlling the parameters that we use the laser, we can use it to root plane. We can use it to remove calculus from the surface of the root without removing hardly any root surface at all. And in addition, by removing the smear layer from the surface of the root, we've got a surface that's biocompatible, something that we couldn't really achieve nearly as well with the curettes or ultrasonic instrumentation. We also completed last year a study that took us 3 years to complete. One of the key findings that made a huge difference in the way that I practiced was the time of treatment. We timed all the surgeries that we had. And on average, I was 40% faster doing a minimally invasive laser procedure than I was a conventional flat procedure. So in our study, we were treating half mouth with laser troughing and a regenerative procedure, or just laser troughing and the other half compared to scaling and root planing. Regardless of whether I scaled and root planed on the conventional side or I did a modified Widman flap on the other side and compared it to a laser on the opposite side, we were on average 40% faster. That allowed me to have practice growth. From about 2001 through now, we've had 10 to 15% growth per year, and I attribute that directly to the laser. In our study, we found that after about a year after scaling and root planing, pockets started to deepen again, and I'm sure you've had that same experience in your own practice. And in fact, in the literature, it shows the same thing, that over time, areas that have been scaled and root planed, the pockets tend to open back up again. We found in the areas that we did the laser attachment procedures, those areas did not open up again after the first year. And in fact, when we followed it through 3 years, the areas that were treated with laser did not tend to break down, whereas the areas treated with scaling and root planing did. Another key benefit of the YSGG laser is its ability to remove endotoxin from the surface of the root. In fact, in Shoup's article, he found that the indirect light beam removed endotoxin from the tubules of the root up to 1,000 microns away from the surface. And that's with an indirect light beam. So your ability to not only clean the surface of the root, but detoxify it is greatly improved. A key question that I had was, this is a water laser, so we know that the erbium light is going to be either attracted by the water or hydroxyapatite. So down deep in the pocket, if I didn't get enough water around the tip of my laser tip, would I be burning the surface of the root or burning the bone? That was really a major consideration. Then Crespi came out with a study where he was treating advanced periodontal disease with a closed pocket procedure using an erbium laser. And what he found was that no, he didn't cause any damage to the surface of the root, and he didn't burn the bone. It turns out that you've always got, especially in a periodontal pocket, you have gingival crevicular fluid flow. So it's not really ever dry down there. And in the technique that I'm going to show you tonight, you actually start troughing from the free gingival margin and work your way down to the base of the pocket. So you're not ever actually cutting with a dry tip anyway. So to answer that question in short, we did not cause any damage to the root surface, and we didn't cause any damage to the bone using an erbium laser in a closed environment. So, does this laser do any good? That was kind of the next thing. Has anybody else used an erbium laser and had any beneficial results? Well, if you look at the top study, the Schwartz study, he's followed his study now out over 3 years. And basically, he found almost a 2 millimeter improvement in 4 to 6 millimeter pockets. Polinick found a little bit more improvement in the areas that he treated. And in our own practice, what we've basically found in the 3-year study that we completed was that in 4 to 6 millimeter pockets, that depth of pocket would very predictably close to a 3 millimeter pocket on single-rooted teeth. On multi-rooted teeth, in the furcation areas, if the furcation was a class 1, we tended to have a 4 millimeter pocket over that furcation. But around the other areas of the molar, we would shrink it down to 3. So, and that's after one treatment. And on the right side of the screen, you'll see me applying this is a topical anesthetic that I'm applying inside the sulcus. On the bottom, you can see a photo. We more frequently use a bender brush to apply this topical anesthetic. So in 4 to 6 millimeter pockets, this is pretty much our routine. We don't typically give local anesthetic. Rather, we're applying a topical anesthetic down into the sulcus. The length of anesthesia is about 20 minutes with this topical. And as I did mention at the beginning of the presentation, if you're going to have a chance to ask me questions at the end of it. However, if you have more questions, you can always email me at my web address or my email address that was published at the beginning and also showed again at the end tonight. So the steps in doing a laser attachment procedure is on the upper left-hand corner. I'm using the laser to first wound the outer epithelium. We know that if I've wounded the epithelium, both in the sulcus and on the outer aspect of the flap, as the tissue starts to heal, epithelium has to migrate under that wounded tissue, then down over the free gingival margin and down into the sulcus or pocket. By wounding it externally, you slow that process down. Then we take the laser and we actually start at the free gingival margin and we remove a slot or we trough the tissue from the free gingival margin all the way down to the crest of bone, removing the lining epithelium. This makes the pocket loose, so now you can pull back on that pocket and actually look down the surface of the root and see the root and the bone. So you've just created a minimally invasive flap. I don't separate the papilla though, so as I'm troughing around the tooth, I've created this slot or trough around the tooth, but the papilla are still connected. That allows the surgery site to heal very rapidly. So after I've troughed, I begin my root treatment with ultrasonic instrumentation using slim-lined ultrasonic tips. And a benefit of using the laser for troughing is that you'll find the calculus on the surface of the root has a different texture or consistency. It doesn't hang on to the surface of the root much anymore. That's due to a photoacoustic effect of the laser. But in any case, the next step is I use the ultrasonics. And then if I've got really heavy debris on the surface of the root, or if I have a groove or a root proximity problem, I will use a slow-speed burr. That's a Brasler 8832 burr to smooth out a groove or deal with a root proximity issue. And then after I've done that, the final procedure is to angle the tip, the laser tip, towards the surface of the root at about a 10 to 20 degree angle. I'm still using the same settings the entire time, 1 watt, 20% water, 11% air, although you may have to modify the water depending on the tissue effects you get with your laser. If you start to see browning of the root surface or the tissue as you're cutting it, then you should increase your water or decrease your power, one of the two. So anyway, I'll aim the tip of the laser towards the surface of the root, and I'll clean the surface of the root. I'll condition it. This removes the smear layer, it removes any residual bacteria or calculus on the surface of the root, and it makes it biocompatible. Again, addressing one of the problems we had with microsurgery in the past. This next slide shows that after I've troughed around the tooth, you can actually pull the tissue back, and you can see down the length of the root. That's what makes this a minimally invasive procedure, but it's not a blind procedure. I don't advocate blind procedures for anything that I do. You should always be able to pull back the tissue and look and see what you're doing. And so when I do surgery, I typically wear 4 to 6 loops, 4 to 6X loops, or I use my surgical microscope. And that allows me to see down the length of the root. I don't believe that you can truly do adequate periodontal treatment with a laser without having magnification. Now we're going to look at a video of this reattachment process. Again, it shows you the settings. The settings are basically the same. We're always using 1 watt. With the Waterlase MD, I typically go 30 to 35 hertz. I'm still 15% water, but if you start to see browning, you would increase your water. Leave the air where it is. So we start by changing or wounding the external epithelium to slow down the progress of epithelial cells migrating back down into the pocket. We trough, then we're going to plane and condition the roots. And then at the end of the procedure, we're going to seal it. We're going to seal it with a glue. So you can see on this video, I'm looking at the video now, and I can see that the tissue is being wounded externally. And you can see as it turns white. So you're not really cutting away any tissue. You're just damaging it enough to slow down epithelial migration. It's a very quick and easy step. Now I'm starting at the free gingival margin. And as I'm wearing my loops, I can see the tissue disappear or ablate under the tip of the laser as I move it down. And that's a key thing. That's the reason you need magnification when you do these procedures. You need to see the tissue disappear under the tip as you're troughing down. And then I'll move the tip back and forth within the sulcus to loosen the tissue so that I'll be able to pull it back later to see the length of the root. Now, if we were doing this